let me know. I'm going to start off with an example, and I'm going to pretend to be a patient and try and show you how I think it can sometimes be for patients to navigate their way through the NHS, which has become incredibly complicated. Okay? So, forget the slide, but just watch me. I'm a patient. I'm going to see my GP. Doctor, I've got palpitations. My heart keeps beating fast. It feels funny, and I'm really worried about it. Now, what a GP would do in that situation would be to take a little bit more information along the history, examine that patient. They then would probably say, well, do you know, I think what you need are to have some blood tests and what's called an ECG. That's a tracing of your heart. What would the patient have to do then? They'd have to go to hospital, right? They'd have to go to the Hallamshire or the Northern in nearly every practice and have an ECG. And they might have some blood tests either at their practice or at the hospital. And then they'd go home and they'd wait for another appointment to go and see their GP to discuss the results. And then they'd go back to their GP, and the GP would say, well, the good news is that your blood tests and your ECG all look normal. But I still feel these palpitations, doctor. They still keep happening, and I'm still a little bit worried about them. Well, I really don't know what I can do as a GP. I think what I maybe need to do is to refer you to see a cardiologist to have a look at these results and have a look at you and see what's going on. So I'd then go home and I'd wait for a cardiology appointment. Now, those GPs in the audience and many patients who attend cardiology will know that you have to wait quite a long time to go and see a cardiologist because they're under such huge pressure from the amount of work that they get referred to. So after some weeks or even months, you go back to hospital again to see the cardiologist. And you'd say, well, I've got these palpitations, doctor. They'd ask you all the same questions over again. They'd say, have you had an ECG done? Yes, I've had it done. Hopefully that will be available, but it might have gone back to the practice actually. So you'd probably have to have another ECG, have some more bloods. The consultant would look at them. And then they may say, well, I think what you need is a palpitation investigation, what we call a 24-hour tape. You wear a machine for 24 hours. So you probably have to go home and wait for an appointment to have that test. And that appointment would come through and you go back to hospital and be fitted with a 24-hour tape. And then you would go home, wait for 24 hours. It usually goes back to the hospital in a taxi. And then you wait for the result to go back to the consultant, and then for an appointment to go back and see the consultant. It may be that that consultant, if they're thinking actually, maybe it's better just to tell the GP that result. So you could go back to the GP, and the GP's saying, oh, the doctor's asked me to do this job, so I'm going to tell you the results, okay. Or you may wait and then go back to the hospital and see the consultant who will say, well, you've had your 24-hour tape test, and I'm pleased to tell you that it's okay. You're all right. And I'm discharging you from the palpitations. So you go home, and you may think about it. If you're happy with that, that could be the end of the story. If you still don't feel quite right, you might make another appointment to go and see your GP just to say, have you had a letter from the consultant? Because I haven't heard anything. And he told me it was okay. Is it okay? And the GP would hopefully be able to tell you and reassure you. Now, I've just given that as an illustration of what I would say is quite a common problem, and a problem that, to me, is not a very complicated problem. But it seems like the pattern of care can be quite complicated, can't it? And I don't know if that chimes with those of you who've maybe been through that very process, or similar ones where there's a lot of toing and froing going on. Or in fact, what might not be that complicated problem. I can see some heads nodding, so it's not going to completely.
We are in agreement.
We're in agreement. Fantastic. So, what we're talking about, cases is just a collection of letters, and it stands for clinical, because what we're doing is we're talking clinician to clinician about this. I've met consultants that I've been liaising with by letter for 22 years, and I've never met. I didn't know what they looked like, and it's been a pleasure to meet them and talk with them. It's about how do we assess the problems that people take to their GPs. What do we do? At the moment, GPs send a letter which contains as much information as that GP is able or willing or wants to put in the letter. And that's what goes to the hospital, and that's what the consultant has at their disposal before they meet the patient. We think we can make that process a lot better. It's about services. What services can we make available to patients, perhaps closer to their homes, that make the process of care a lot easier for them? It's also about education, and education is key, absolutely key to this process, because it's about educating us GPs so that we can feel confident that we can perhaps do more, and that we can pass that confidence on to you as patients so that you feel like you're really being looked after well without having to go to hospital. But it's also about education for the whole system, about how it can work better. And it's also about giving more information to patients so that they can manage things for themselves. And it's about supporting everybody in this, but particularly we're really keen to find ways that patients can actually look after their own health, find ways to do the right things whilst they may be waiting for an appointment, to get started with their care, to know what to do, to have more information. So that's what it means. That's what we mean by cases. So I've described this already. This is a traditional view of how the relationship is between primary and secondary care. We've got a tradition of GP practices that do a vast quantity, 90% of all NHS contacts are with primary care. And they sometimes stray into the territory of doing a little bit more than, as Graham said, as is contractually required. We push the boundaries as much as we can. But when we feel we've reached our limit and the patient needs more, they get referred to a hospital. And that's a big collection of buildings, isn't it, where everything happens. And hospitals do their stuff, but they also do a little bit of this if they feel that the practices, they can't guarantee that the practice is going to do all the stuff that maybe should happen. It's not that this is what I would call a dysfunctional relationship. It's not that we don't like each other. It's just that we never talk to each other, the GPs and the consultants. It's hard for me to ring a doctor in the hospital to say, what should we do about this? It's lovely when you get the chance. It makes things so much easier. But they haven't got the time to do it. And often we're talking to more junior doctors than ourselves. And the consultants at hospitals don't like that, and we don't like it. But we haven't got a system that gives us all time to sit and wait for phone calls. So we don't meet and we don't actually communicate as effectively as we could. And we don't give patients the opportunities, I think, to care for themselves in the way that we could. And the other thing that's relevant to us in Sheffield is that there's this difference between what's called secondary care and tertiary care. Tertiary care I describe as the really specialist stuff, and Sheffield's great. If you've got something that's rare, that needs very specialist treatment, Sheffield's a good place to be. And many of the consultants are attracted to Sheffield because of that. But we don't always feel that general secondary care, like you get from District General Hospital, is always so available. Because actually people's interests, if you're trained to be a doctor, you have interests and you want to do the most you So that's sort of where we are. What we're trying to describe is not a new building or a new organisation, but just a way of doing things a bit differently. So we've got practices as before, we've got specialist care where it is. We see cases as a process in between those two that's continually working across the divide. And we're really trying to make primary and secondary care much more integrated. And it goes further than just where you are, which seat you're on, in which place. Because the way that we often behave is when I send somebody to hospital, I sort of forget about them. You know, I wait for them to come back. I don't always necessarily feel that those palpitations are my responsibility anymore. I've given them to the hospital now. That's not true, really. You'll still come and see me if you're troubled by them, and I'm still responsible for you. But we send people into the black hole, and we don't want to do that. We want to be in partnership in the care. This is where the arrows will go on. So by doing that, we want to give practices through education, through time, through resource, an opportunity to do a little bit more. And I'll try and explain with a scenario how that might be. We want to increase and improve the communication between GPs and general practitioners who have a special interest, and there are many. You will know that there are GPs in your practice who are very interested and very experienced, or may do hospital clinics. We also have consultants who want to work in the community and want to engage more and want to educate us all more. We want to work together more. And we want that system to be joined up, and we want it to be focused not just on self-care, but we want it to be focused around the patient and the journey that they take through the hospital system. I'm going to explain it another way now. Are you with me? Okay. It's racing ahead. So, another way of looking at this is just how we structure it, how we put it together. So a GP will still refer the patient into, instead of directly to the hospital outpatient clinic, where a whole host of different responses can take place depending on which specialty, which consultant looks at the letter, whatever. But we want those referrals to go into the system, joined up between primary and secondary care, so that someone with some specialism, could be a consultant, it might be a GP, it might be an arrhythmia nurse. You know, this patient with palpitations, if they go to hospital, they'll see a nurse, not a consultant. They'll see an arrhythmia nurse, whose job it is to see people with palpitations. Fantastic, fantastic. But that person might look at that referral, and it might say, "Dear doctor, this patient has palpitations, please see and advise." That can be the limit to the information that's given to the hospital. Sometimes it's a screed, investigations, results, a question. What do I do with this patient next? I've tried this, I've tried it. It ranges from one extreme to the other. We want a system where that information is looked at, and if the response for that person is, they don't need necessarily to go and see a consultant. Let's make sure that all the right investigations have been done. It might be that there's something that can be done in the community. It might be some diagnostic tests that can be done in the practice, in the neighbouring practice. It will be blood tests. It will be an assessment. And then what might happen is if that patient is actually not thought to be suffering from a serious condition, and you can question me on this, but we can actually make quite a good judgment sometimes from the information that we're given. We can say to that GP, actually, do you know what, we've answered your question, but the patient doesn't need to be seen face to face in hospital. And if that works out for the patient and that works out for the practice, then I would have thought everybody's happy. But it may be that people need to be seen face to face by somebody with expertise. But we're questioning whether that always has to take place in a very busy outpatient department where it's difficult to park, and so on and so on. And is there a way we can make those clinics available to people in the community? Not just for the first time, but maybe for some of the follow-ups that people will need. We also want to make use of technology. If you've got a mole that you're worried about, or a spot or a rash, there's a lot of work that's been done over the years about saying, rather than waiting a few months and then sitting and waiting in an outpatient clinic to see a dermatologist to look at it and say, it's that, and do something, we can send a picture with the right information. And that's been done across the world in many places. It's not been done at scale in the UK, but the dermatologists here, I think, are up for it, and we can make that happen so that it's the information that travels and the patient doesn't have to carry their spot all the way to outpatients. Okay? And we want the education and upskilling to be integral to the process. We were really keen as GPs in the CCG for our consultant colleagues to be coming out in the community and educating us at lunchtimes, educating patients, getting the nurses out to do education about how to apply treatments, and all sorts of activities that currently are just locked into the hospital. And that also ties in with some of the things that have been taking place across the city, with either good quality information, or health trainers, or teaching nurses and healthcare assistants new skills so that they can pass on information to patients so they can manage things. So that's another way of looking at it. Are you still with me? Does it make sense?
Yeah.
We'll look at that. So should we break or just carry on? So I'll do the scenario. So what I'm going to tell you now is how I think it could be for that same person if we had this system working well. Okay? So I'm the patient here. I've got to see my GP. Doctor, I've got these palpitations. My heart keeps fluttering and beating, and it makes me feel worried and frightened. So the doctor would take the same history and say, well, I think you need some bloods and you need an ECG. Now, in my practice, we've done ECGs for the last 25 years, so it's actually, just go and see the nurse, get a blood test, I will get your ECG. Then the patient will probably go home. And when we've got results of the laboratory test, we've got the ECG, they can come back and see me again. I'm pleased to tell you that your bloods, your ECG test look...
Charles, can you speak up a bit?
Yes.
I'm sorry. I'm pleased to tell you that your bloods and your ECG look normal. But I'm still worried, doctor. And they're happening too often. I don't like it. I'm worried. And in that case, I think what you need is a 24-hour take test. That's the usual next step. I'm just going to ask you some questions to make sure that you're not at high risk of heart disease. If you're at low risk of heart disease, then it's fine for us to maybe just organise this test and see what the result is like. So I would then ask the patient to go home, and they would get an appointment, either at their practice or at a local practice. Now we have that facility in the city now to do 24-hour take tests at 7 or 8 different places in the city. And then what I would want as a GP is I would want that result gets looked at. So the next thing is the patient would come back to see their GP. And I would be able to say as the GP, well, I've been informed by the specialist who looks at ECGs and 24-hour tapes that actually there's nothing alarming in your 24-hour tape test. And I'm telling you this with confidence. And can I reassure you enough that you don't need to worry about this, or we can do something to try and dampen these down if you stop drinking tea or coffee, all that sort of business. So what I'm saying is, in many cases, that's the end of the story. If you notice, I haven't been to the hospital. I've had fewer visits. It's happened in my home. On the other hand, if that were actually, the story was, well, I'm sorry to tell you, but we found that sometimes your heart slows down a lot, and you may be getting dizzy at times, you might need a pacemaker. You still go to the hospital. If you need that sort of specialist intervention, that's what you get. But for many patients, it won't get that far, because we want to be able to do that as close to people's homes as possible. And we want to do that across the board if we can, but we can't do everything at once. So we've been doing this, we've been engaging with 5 specialties: cardiology, respiratory medicine, urology, ENT, and dermatology. We've had meetings with them. We're talking about how we might shape this. And this meeting is an important early step in that, to find out what you think about it and how it might work. We think that what it means is that every time you go and see a doctor or a nurse, it does something. You're not just waiting, you're not just being given a piece of news that doesn't change things, but we want things to have a good outcome. We want you to be able to spend more time nearer your home and less in hospitals. But we do feel there are great benefits to the whole system. It means that we're more joined up. It means that we're doing this education. We also are trying to get consultants to join us in being responsible for the care of patients across the whole community. Because currently, if you're a consultant, you see the patients you see. You don't see everybody. GPs manage a lot of it. There's some things we could do better, and the more we're joined up, the better.